Hi, this is Clyde Yancy. I am here at the 15th annual Heart Failure Holiday Symposium from Northwestern Medicine, and it has been an absolutely fabulous day. I've got my colleagues, my peers here to really help break this down. Kathy Grady is to my left, Jonathan Rich is next to Kathleen. Nancy Sweitzer from Arizona came in for the good weather in Chicago, is with us, and then of course Jane Wilcox. We have had a fabulous time. I think I can collectively say wow for all of us. What a fabulous morning so far. Just thinking about the big takeaways, particularly for the practitioner or maybe even the nurse practitioner who's having to digest what she or he might have heard today. What are those takeaways?
You know, I think for the clinicians, for the nurse practitioners, there is new therapies. There are new therapies out there. We have patients going home on LVADs. They really need to understand all of the new changes. They need to work with patients in terms of learning to care for themselves, their self-care, education, going out the door, and then the chronic follow-up. These are chronically ill patients, and they absolutely need to be able to take their medication as directed. They need to take care of themselves. If they're having barriers, challenges, support issues, back to the nurse, perhaps off to the social worker to help. It is team science, and the nurses need to be very integrated into that team, working with the physicians, with other team members, pharmacy, psychology, social work, and everything that we've heard today, I agree with. Wow, that's got to be incorporated into their practice.
So didn't we also enjoy that not only do we have these new therapies, but they actually help people feel better.
Yes,
and some of the therapies
do.
are uniquely appropriate even for older people. So Nancy, I know you've been paying attention to the SGLT2 story. I mean, if there's a headline this morning, it's people wake up, there's a new kid on the block. But we've got good data about minimum side effects and even data extending into older persons. Give us 2 sentences, the takeaways about the SGLT2 inhibitors for heart failure.
Well, I think the DAPA-HF trial was a real home run. The drug works to reduce not only symptoms and hospitalizations, but death. And data that looked at the effect across the lifespan presented at AHA showed that the drugs are just as effective in the over 75 age group as the under 55 age group. I think the challenge for all of us is incorporating it into our practice. I think many people still think of it as a diabetes drug, not a heart failure drug, and learning how to use it and manage the side effects on top of all the other therapies we're giving is going to be something we all have to take on.
So I think that is a wake-up call. This is no longer in the diabetes space. We have to get accustomed to it, but the good news is that at least for dapagliflozin, it is 1 dose, 1 time a day, no titration. We should be able to figure that out.
We should.
But Dr. Wilcox, what's very interesting, remind everyone that we started last night with a really wonderful conversation about the complexities of doing research, and what emerged was this surfeit of treatment options. How do you navigate this? And thinking about that, we talked about the genetics of heart failure today. We talked about different kinds of cardiomyopathies. It's not all one type. What are your takeaways for the audience thinking about, okay, this is a new ball game, this different profile for different patients? Give us some insight there.
So I think we're getting away from LVEF as a diagnostic criteria, and LVEF is more of a biomarker and looking more at the myocardial substrate. So in identifying patients who may respond to therapies, and so using ancillary imaging, genetics, as we talked about. Dr. Wilsbacher did a fantastic presentation of sort of tips and tricks and how to integrate genetic testing and how to increase awareness for heart failure so that we can move into the prevention space. So really outstanding, and I think we've talked before about the ARNI space, and it's not just an EF of 48% and an EF of 35% could be the same type of patient that just has, at a different point in time. And so the biology is the same and the response to therapy would be the same. And so we really need to be more thoughtful in our approach to responders.
So why don't you and Nancy stay on that point, because you shared data demonstrating a potential benefit of the ARNI compound up to an ejection fraction of over 50%. I mean, are we having to redefine what is HFrEF?
I think absolutely, particularly in women. The data presented about the sex differences in ARNI responsiveness at AHA when they combined Paradigm and Paragon showed that women seem to respond up to quite high EFs, higher than 60 even. And so it'll be interesting to see what the regulatory bodies and the insurance companies do, but I think there's certainly evidence that women gain benefit of this to a much higher ejection fraction than men, and whether a normal ejection fraction in women might be a higher number, and an EF of 60% is actually LV dysfunction in women of a certain age is a question I think we need answered.
So I think all of us agree that what's wonderful about clinical trials is that they give us more questions to have to answer. So one question to answer now, particularly in the context of recovery, what is a normal heart? I mean, how do you identify normal now?
So I think it's easier to see what's not normal than what's normal. I'll start with that. But I think as you know, it's always good to have a pie in the sky sort of moonshot. We're going to get to normal, but even getting to a little less than normal or myocardial remission, where biomarker profile is normal, patients are asymptomatic. That I think is a meaningful target that we as a community probably should be shooting for, as opposed to truly, normal. I don't have a great way of quantifying truly normal, I guess, at this time.
But it does make us have to think. We used to just throw an ejection fraction out there and say that's it, but it makes us have to think. So Jonathan, Jane did a brilliant job making the argument that if you continue to titrate evidence-based medicines, there are indeed patients who will see an improvement not only in the ejection fraction, but their quality of life, and we think maybe some clinical outcomes. But we all know that they don't always respond that way. And then those patients end up in your lab with abject LV dysfunction, maybe even needing VADs. We actually have reason to be both excited about LVADs, but a little concerned about transplant. Kind of frame that up for us.
Yeah, no, that's great. A great question. And it's true. Heart failure remains a progressive disease. With the current therapies that we have, we think that in some patients, as Dr. Wilcox described, we can actually make their hearts truly better and maybe even keep them there, or at least we can kick the can down the road for a lot longer before the heart syndrome continues to decline. But I think we do have to accept the fact that many patients with heart failure will see a progression of their heart muscle dysfunction to the point of end stage, or we call advanced heart failure, needing therapies like LVAD or transplant. On the exciting side of things, LVAD therapies have just been improving and improving over time to the point that we now have at least 2 very viable, durable VADs on the market that have been shown unequivocally in this patient population to improve survival, improve quality of life, exercise capacity, sometimes is what we call destination therapy, but sometimes as a bridge to transplant. Now, you mentioned transplantation. In the long run, I still believe, despite the improvements in VAD technology, that for many, if not most patients, a heart transplant is perhaps still the way to go in the long run. But the field is changing. Data are emerging that suggests that if we're trying to be too aggressive and transplant patients who are too unstable, that the outcomes that we've been realizing up until now, which have been relatively good, may actually not be as good anymore. And so what we're all having to try to grapple with is we have a patient, we know they're going to need a therapy like an LVAD and or a transplant, but what is the right pathway to get them there? Is it an LVAD first, get them out of their heart failure syndrome, and then get them transplanted, or is it straight to transplant? Still to be determined, but that's why a collective multidisciplinary group like this gets together every single day, multiple times, to discuss these complicated cases.
And once again, we learn so much from data. We wouldn't know what you just said if we didn't make the effort to collect the data. But I think everyone will agree, despite the excitement we have, one of the most important themes that emerged this morning was we need to try to prevent this condition. I always like to do these kinds of weekend meetings with one important objective. What can the practitioner do differently on Monday morning based on what we've discussed? Everything we've talked about has been theoretical and wonderful, but Monday morning, what about treating hypertension, Jane? What should we do differently about that Monday morning? Quick answer.
Be aggressive. Vote early, vote often. Be aggressive. I would say be aggressive because we know that it's the single biggest risk factor in the risk for heart failure development.
Yeah, it was about an 8-fold increase in risk. And Monday morning, what should we do about the diabetic patient that walks in the office and we're thinking about heart failure?
Well, the SGLT2 inhibitors have clearly been shown to prevent heart failure at a very astounding rate in diabetic populations. But I think, if I can just divert a minute, I think the big lesson is Monday morning, assess risk for future heart failure in your patients. There are risk scores now,
Yes.
and we don't use them. We do use them for coronary risk all the time. We need to start using them routinely to assess heart failure risk and be more aggressive in those patients who have heart failure risk.
And what about lifestyle? The two of you, Monday morning, what should be our narrative about lifestyle to prevent heart failure?
I think to begin with, we need to understand where the patients are at in their lifestyle. We need to encourage more exercise, better diet, and it's not just a 5-second discussion in the clinic and they're out the door. It's working with a dietitian, working with exercise physiologists in order to really help them incorporate lifestyle change into their everyday life.
And does it work?
I think it does work, but one thing I'll add to that is, as we always know, it's always easier to stay out of trouble than to have to get out of trouble. I think we have to be more aggressive earlier, even in schools. We need kids to start getting up and exercising. Obesity is growing, diabetes is still a problem. If we don't hit it early on, we're going to have more adults who are suffering from disease.
And in addition to survival as an endpoint, we've got to look at quality of life as an endpoint. Perhaps as a secondary endpoint, how about as a primary endpoint? Because it's not just about how long you live, it's about how well you live.
So if you're listening to this, I don't know how you can't sense the enthusiasm, the quickened pulse rate we all have, our excited eyes. I mean, for those of us that have been in this field for a long time, this really is a new day in heart failure. We captured a lot of information in just the first half day. We have more to cover. But remember, heart failure is preventable. If you have the condition, it can be treated in a variety of different ways. We can identify patients differently and better than ever before. We have bailout strategies when they get very ill. We can recover some patients. Don't forget about lifestyle. We think this is a new day in heart failure. Thanks for your time and attention.